Good day to everyone and welcome to today's section on the Climate and Health Responder course. I'm Marian Offei, your moderator for today. I'm the coordinator for the Association of Schools of Public Health in Africa, which is based at Accra, where the secretariat is in Ghana. Today's section, we are going to look at vector-borne and zoonotic diseases. Before we start the whole course, we are going to go through some few housekeeping information. So as you already know, there will be interpretation in French and Portuguese, and also there will be a final exams at the end of this course. A minute. There will be a final exam at the end of this course, which is based on your attendance for the course via Zoom, and also your final score at the end of the exams. This will be looked at and the certificate will be awarded. You can switch to the various languages you prefer. A second. Good. Good. So today's section, we are going to look at vector-borne and zoonotic diseases, which will take about 90 minutes, as you all know. So in today's section, we are going to look at the environmental processes changes as a result of climate change and how they impact prevalence, incidence, and distribution of vector-borne zoonotic diseases. We will also describe how climate change is influencing their distribution. Example, malaria, Rift Valley, Schistosomiasis, and also bringing forest habitats in closer proximity to humans. We will also explore what actions health professionals can take to identify and protect patients vulnerable to these diseases. In today's section, we will define steps the health sector can take to become prepared to address shifting geographic burdens of vector-borne and zoonotic disease, including increasing surveillance and early warnings. We would have two presenters today. The first presenter, which is Dr. Desiree LaBeaud. She is going to take us through the main presentation and would have a case study by Dr. Adugna, Professor Adugna Woyessa. So we are going to kickstart today's section with Dr. LaBeaud. Okay, so Dr. LaBeaud is a physician scientist, epidemiologist, and a professor in the Division of Pediatric Infectious Diseases at Stanford University School of Medicine. She's earned her master's degree in clinical research and epidemiology at Case Western Reserve University. She studies the epidemiology and ecology of domestic and international arboviruses and emerging infections, with an interest in the vector, host, and environmental factors that affect transmission dynamics and spectrum disease. Her research is community-gauged and seeks to define and then disrupts the underlying structural determinants of health. She studies the human health impacts of climate change, including research focused on innovative solutions to the global plastic pollution crisis. Her current field sites include Kenya, Grenada, and Brazil. She currently has a clinical research lab focused on better understanding the risk factors and long-term health consequences of arboviral infections and the most effective means of prevention. She has also recently launched a nonprofit Health and Environmental Research Institute in Kenya, which is an initiative focused on Kenya to inspire community education, new research, policy change, and grassroots activism in environmental health. We shall now invite Dr. LaBeaud to take us through the 40 minutes presentation. Thank you very much.
Thank you very much. Hopefully everyone can see my screen okay? Yes?
Yes, we can see
Great.
it.
Thank you so much. Thank you very much for the introduction, Ms. Marian. So today I'm going to be talking with all of you about the environmental processes changing as a result of climate change and how they're impacting the incidence, prevalence, and distribution of vector-borne disease We're going to look at key vector-borne diseases: malaria, Rift Valley fever, schisto, dengue, Chik, and Zika. And then we're going to explore what actions health professionals can take to protect patients that are vulnerable to these diseases and become prepared to address the shifting geographic burdens of vector-borne disease across Africa. So as many of you know, and as you've been talking about in this course, climate change really does impact a lot of different systems within human health. Today, again, our focus is going to be on this green box to the right, which is looking at the changes in vector ecology and how that mitigates risk or exacerbates risk for these vector-borne diseases. Before I really get started, I just want to mention that we can't look at these systems and we can't think about vector-borne disease without thinking about how we are all connected in a web of life. Vector-borne disease is at the middle of a system between the vector and the host, the virus or the pathogen, the parasite, and the environment. And climate change is shifting all of those natural systems, the range, the life cycle, the growing pattern and disease dynamics of so many different living organisms. And so human health, as we all know, is inextricably linked to the health of animals and plants and other ecosystems on our tiny planet. And so you must take a One Health or planetary health approach when you're thinking about how to evaluate and protect people from these risks. Because changes in climate really influence the habitat suitability and reproductive rates for the host, the way that organisms move in the environment, and the way that these risks are felt. So I get to talk to you about the world's most deadly animal today, which is the mosquito, which kills almost 1 million people every single year. And this is, of course, because they carry deadly pathogens. We're talking about climate change. And when people think of climate change, often they think of, the polar bear with his shrinking ice cap. We know that burning fossil fuels leads to increased temperature, that leads to sea level rise and decreased ice mass in the world, and also shifts in flower and plant blooming. But also, it leads to alteration in mosquito habitat. There are extreme weather events and warming temperatures that can all have an impact on mosquitoes and therefore the diseases that they carry. So instead of just thinking about that polar bear when you think about climate change, hopefully after this session today, you'll be thinking about mosquitoes as well. These mosquito-borne viruses and pathogens are really emerging and re-emerging in our world today. They're becoming more and more common, and that has a lot to do with the influences of modern life. So we live in a much more urban than rural world now. And so with that comes sanitation challenges and crowding, which can increase risk. We as humans also like to change our planet. We cut down trees, we reforest, we reclaim land, we do irrigation projects, we build dams. All of these can have an impact on mosquito habitat. Unfortunately, we live in a world that is full of war and military activity, and of course that can abort any sort of control or surveillance that was going on before that war activity began. And unfortunately, we have a very limited toolkit when it comes to effective vector control. We also live on a very tiny planet, and we move around quite a bit as humans. And so we can carry pathogens with us, and we can get anywhere in the world within about 24 hours. And so we can carry these pathogens on our planes with us. And then, of course, there's climate change. So there's natural disasters, extreme weather events, and the reduced capacity to sustain clean water, all which can have an impact on vector-borne diseases. So I'd like to ask the question, and this is what we're posing here: how will climate change affect vector-borne disease transmission? I want to start with my very most favorite virus, which is Rift Valley fever virus, a virus that I've been studying for about 20 years in Kenya. So this is the life cycle, of Rift Valley fever. And so Rift continues in an enzootic cycle where in nature, it's sort of maintained in floodwater Aedes mosquitoes, where the mom mosquito can pass the infection to her egg. And those eggs are very desiccation resistant and can lay dormant for years, infected with the virus. And then when rains come, heavy rains, El Nino rains, or just seasonal flooding, you get a huge bloom of these mosquitoes that are already infected with the virus. And then secondary hosts and amplifying hosts such as livestock, will come to the water to drink, and these Aedes mosquitoes will feed on those animals. The animals get very high viremias, a lot of virus in their blood, so they're able to pass the infection on to other mosquito species, many different mosquito species, which feed on them and then feed on us as humans. Humans can also be directly affected and infected by their animals by animal husbandry activities.
Hello, Dr. Labo.
Yes.
Kindly speak a bit slowly for us.
Of course, will do.
Thank you.
Thank you. Okay. Especially when I'm talking about Rift, I get very excited and I speak very quickly. So Rift Valley fever is a mosquito that is spread by, it's a virus that is spread by these Aedes, these flood-borne Aedes mosquitoes. But again, humans can also get infected by animals. And the animals can get very, very sick with this infection. Many young animals die, pregnant animals abort. And so when humans are helping the animals through this infection, oftentimes they can even inhale the virus and get it through the aerosol route. This is a bunya virus. It was first reported in Kenya in the early 1900s when there was a large epizootic among sheep, where there was a huge abortion storm in sheep. And so episodic epidemics, which are becoming more frequent, really do present a significant natural threat to human health because the virus can cause severe sickness in humans. Most humans just have a self-limited febrile illness, but they can have a lot of eye complaints. But a small proportion of humans, around 1%, can have severe disease. And Rift Valley fever in that case can lead to about a 50% mortality with problems with hemorrhagic disease and also infection of the nervous system with neurologic disease. As I mentioned, the life cycle of Rift Valley fever virus is really climate connected. It's very much tied to rains and flooding. And you can see here in an area that is endemic for Rift, when it floods in some of these areas, the type of soil that's there doesn't really absorb all of that water, and the water just sits, creating a perfect habitat for these mosquitoes to propagate. As I mentioned, I've worked on Rift for many years, and so I'm just showing you the difference of one of our homesteads in our study during dry season and during rainy season. So you can see just how the place greens up and how it gets flooded. And this, of course, definitely propagates risk for this virus. So NASA has used the greening up of areas to actually help produce a Rift Valley fever monitor across Africa so that folks in the ministries of health can know when Rift may be circulating. And the way that they do this is they actually use the normalized differential vegetation index, the NDVI, the greening up of plants, to actually show when there's more rains and therefore when there's more risk for potential Rift Valley fever outbreaks. This is important because it gives this early warning system sort of gives a lead time so that ministries can go ahead and decide whether they're going to vaccinate their herds for Rift Valley fever because there is an effective animal vaccine. But it's not perfect, right? Because this model only includes climate data and doesn't include herd immunity data, which can definitely change whether or not an outbreak occurs when the conditions are right for an outbreak to occur. So if we think overall about Rift and climate change, we can imagine that climate change is expected to increase the risk of Rift Valley fever in several ways. There's going to be increased breeding grounds because of the increase in frequency of strength of El Nino rains. Geographic range may expand. And because Rift can be spread by so many different mosquito species, this can really be of importance. There's increased extreme weather events, of course, in climate change, such as floods and drought, which can exacerbate the size and number of Rift Valley fever outbreaks. Because humans are having difficulty maintaining water, we build dams. And so that land use change that's associated with climate change can also initiate new outbreaks of Rift. And then finally, warmer temperatures can, of course, prolong mosquito seasons and make the virus develop more rapidly in the mosquito. And so that can have an impact. And we know that temperatures are rising, right? So if you look at this graph just showing pre-1970s and then post-1990s, you can see that there's been an increase in temperature across Africa. And it used to be that people would think that with increased temperature, there would just be more and more of these vector-borne diseases, sort of in that upper panel on the right side. The model was, a linear one, that with every degree of temperature rise, there was just going to be more and more and more vector-borne diseases. And this is not the case because this is not how mosquito biology works. So it turns out that there is actually a temperature optimum by which all the temperature dependent processes in the mosquito function. And so it can be too cold for that to be optimal, and it can actually also be too warm. And so this is a really important finding because you'll see that it influences the way we think about how warming and global warming is going to impact these mosquito-borne viruses. If you think about the temperature curve and that temperature optimum, let's say, of any given mosquito-related disease, what we're looking at here is malaria, the relative R0, which is the amount of risk for propagation of that disease, will change depending on where you are on this curve. So if you happen to be in the place in the world where it's fairly cold where you are and the temperature goes up by 2 degrees because of global warming, you may not see a big impact in the amount of vector-borne disease that you're having as the temperature rises. But if you're in a place where you're on the upswing of this curve and the temperature goes up to 2 degrees, you may have a very large increase in the amount of vector-borne diseases you see in your area. If you're already at the temperature optimum, maybe a 2-degree change won't change the amount of disease so much. But if you're already a little too hot for the temperature optimum and it gets 2 degrees warmer, there may actually be a change in the decrease. You may actually decrease and see a decreased amount of vector-borne disease where you live, and that those diseases actually burn out in your area. So if we take this system and we think about a very important vector-borne disease, malaria, we know that there are many malaria traits that are temperature dependent. The biting rate, the mosquito infection rate, how competent the transmission is, the development of the parasite within the mosquito, how quickly that happens, the death rate of the adult mosquito or the egg to adult survival, the number of eggs that are laid, and then finally, the development of a mosquito from egg all the way to adult. All of these are temperature dependent processes. And so you can take lab data of mosquitoes, Anopheles gambiae raised in the lab, and you can see what is actually the temperature optimum for all of these processes. And my colleague Erin Mordecai did this and actually found that the estimate of the temperature optimum for malaria transmission is actually lower than what it was previously thought. Previously, it was thought around 31 degrees Celsius. But actually, she found that Anopheles gambiae, all the processes actually peaked around 25 degrees Celsius. And so when you think about malaria, and climate change, again, we're talking about temperature in that graph, but it's more nuanced than that because there's more than just temperature, right? It's quite complex. There's water, there's CO2 concentration in the air. All of this can have impacts on soil and whether or not the vector abundance is higher or lower, right? Increased CO2 concentration may lead to wetter soil, and that could increase Anopheles vector abundance, but decreased soil moisture at higher temperatures could decrease that, right? And so it's nuanced, and there's many different factors that we have to think of all at once. It's quite complicated. So we actually went to the field. I've been working in Kenya for about 20 years, and we went to our sites in Kenya to really ask the question, is this temperature, these ecologic models, is it even relevant to what we see in the clinics when we're seeing children who are coming in sick with fever and malaria? And so we were working in Kenya, in Western Kenya and also coastal Kenya, and enrolling children who had undifferentiated febrile illness to our clinics, and also collecting information on temperature and rainfall, humidity in our 4 study sites. And you can see in red there the percentage of malaria at our different sites, children coming in with fever, how many of those were blood smear positive. You can see it varied in our different sites. And when we actually took a look at smear positivity at our 4 different sites, and we controlled for rainfall and bed net use and sex and age and socioeconomic status, we actually found that the smear positivity rate peaked at all of our 4 sites at 25 degrees Celsius. So it was shocking, actually, how well what we saw in the clinic actually mirrored what we saw in our ecological models. And when we looked across the different sites, you can see Chilaimbo, which was our area that had the highest malaria incidence, actually was around 25 degrees most of the time of the year. So when we think about what's going to happen with climate change and malaria across Africa, it's not that everything's just going to get worse everywhere. It's that there's actually going to be a shifting burden of malaria in Africa potentially, and that areas that were really high may get too warm for malaria. Maybe there will be actually a decrease in malaria, and the burden will shift across the continent. Okay, let's move on to schistosomiasis now. So schisto, 85% of the world's cases of schistosomiasis are in Africa, where prevalence rates can exceed 50% in local populations. We know that the life cycle of Schistosoma mansoni and Hematobium involves freshwater snails as intermediate hosts, and these snails release cercaria, which are the infectious form, which then penetrate the skin of humans who come into contact with contaminated fresh water. Hematobium attacks the urogenital system, causing bladder pathology. Chronic infection can lead to even bladder cancer. And there's also female genital schistosomiasis, which can lead to infertility and increase susceptibility to sexually transmitted diseases. Mansoni instead attacks the intestinal and hepatosplenic circulation, and therefore chronic infection leads to liver fibrosis and portal hypertension. And the ways that we prevent schisto is that we focus on snail control, on sanitation, on health education, and on mass drug administration with praziquantel. But just like we were talking about with malaria, there's actually a temperature optimum for schisto. So it turns out that a lot of the physiology and a lot of the parts of the life cycle of schistosomiasis are temperature dependent. You know, the egg production from the snails, the cercarial emergence from the snail, how long the snails live, how long the cercaria live, all of these things are temperature dependent. And so you can create a curve of temperature optimum also for Schistosomiasis hematobium, as you can see there on that graph. And you can do the same thing for mansoni. And you can see about 25, 26 degrees is where these organisms have peak performance. So when we look across Africa, there are places, as you can see in those top panels, in the orange and red, there are places right now where there is the correct temperature and habitat for schisto to actually transmit. And when we project with a warming world, with climate change, what will happen to schistosomiasis, you can see in that blue area across Africa, those are the areas that are for mansoni on the left and hematobium on the right. The blue areas show where there may actually be a decrease in schistosomiasis transmission because it gets too hot and past the temperature optimum for schisto, versus the red, which will come into the temperature optimum for schisto and therefore potentially have an increased risk of schistosomiasis transmission. But again, with schisto, it's not just about the temperature. And I know this is a very complicated figure, but I'm just going to touch on a few things. So temperature, like we're talking about, there are definitely a lot of physiologic traits in schisto where increased temperature is going to provide increased risk for schisto because there's increased survival of the snails potentially to a certain point once it reaches it, and you know, as long as it's before the temperature optimum, right, that thermal limit. There's potentially increased snail abundance and geographic range, right? But if it's too hot, you may actually decrease those things. But also, of course, rainfall has an impact on schisto because the snails, of course, depend on water for their life. And so, you know, with increased rainfall and floods, there may be establishment of new populations of snails, right? New areas of risk, new habitat for them. But if you have too much rain, right, there's actually a potential that then you may be able to wash out habitats and eliminate snails because they don't like fast flowing water. Drought can have an impact because when there's scarce water, both the snails and the humans sort of congregate and concentrate around these small areas of water, right? And so maybe there could be increased contact with infested waters. But of course, if it's really hot and there's a ton of drought and the ponds dry up, then of course you're going to have increased mortality of snails. And then finally, there's the land use changes, right? So again, we change our land. We build dams and irrigation systems. And this, of course, leads to increased risk of schisto, right? Because with that agriculture expansion, we need to feed the world. And so, the way we do that, the chemicals we use, some of that can be good for the snails and good for schisto transmission. So it's quite complicated. Climate change is really nuanced, and it may actually bring, again, it's going to trigger adaptation strategies that actually might bring people and parasites closer together and drive up schisto transmission around dwindling water sources. And then when we look, this is just a figure of all the dams that are planned in the world. You can see that there are already many dams in the world, but there are many, many more, hundreds planned. And so, of course, when we change our land like this, it changes habitat. And two of the organisms I've just talked about, Rift Valley fever and schisto, have both been shown to have, explosive outbreaks after dam construction. So it's just something to think about as we're changing our land. So if we try to summarize what's going to happen with schisto and climate change, and this is from a great meta-analysis that was done in 2019. Overall, there may be a decrease in the central areas of schisto's environment niche right now because temperatures might increase past, the thermal optimum for schisto. And so schisto may lose some ground, right? There, schistohematobium. But because there's the areas that are going to come into a perfect range for schisto, it may be in those cooler range margins now that there's going to be an increase of schisto in those areas. And so again, just like malaria, climate change is likely to shift schisto transmission and shift schisto burden rather than just expand it across everywhere that it is now, right? So it's more of a shift. Both species already are existing near their thermal optimum and even past it. And so, of course, there's always the question of, are the mosquitoes and the snails going to adapt, right? Are they going to adapt to this warmer weather and then still be able to transmit? And that's always possible, right? And then, of course, the snails and the parasites can adapt and move in these places. And so that will have a big impact on what we see in the future with schisto. Okay, now moving on to dengue, chikungunya, and Zika, which I study quite often. These are infections, viral infections that are spread by Aedes aegypti and Aedes albopictus. And so dengue is part of the flavivirus family. There are 400 million infections worldwide. It's the most common mosquito-borne virus, and there's 4 serotypes. Luckily, most of the infections are actually asymptomatic, but when you're ill, you usually get a high fever and headache and what they call breakbone fever, really painful myalgias. And unfortunately, some people, especially those who get their secondary infection, so their secondary infection because they are now getting infected with a second serotype, they can have progression to a capillary leak syndrome and shock and even death. And there are dengue vaccines that are coming out, but they're not widely available right now, and there's no directed therapies for dengue. Zika is a related flavivirus. It's another flavivirus, initially isolated in Uganda, spread by Aedes aegypti mosquitoes as well. Again, many cases are asymptomatic. It does, when it's symptomatic, cause sort of a dengue-light syndrome with, lasts longer, is less severe than dengue, but severe cases of Zika have been reported. And of course, importantly, Zika has been associated with microcephaly, which has long-term devastating impacts on children and families because it affects the brain, the eyes, the nervous system, the endocrine system of these affected children who are impacted in utero. And then there's chikungunya, which is an alpha virus out of the togavirus family. But the syndrome, the clinical syndrome with chikungunya looks much, much, much like dengue with high fevers, arthralgias. The one thing with chikungunya is oftentimes you also get arthritis and joint pain. And this joint pain in some people only lasts during the bit of disease, but usually it lasts for weeks. And in some people, years after infection, they're still suffering from joint pain that was brought upon them by their chikungunya infection. So again, these viruses are spread by Aedes aegypti, which is in panel A, and Aedes albopictus, which is in panel B. And so again, these mosquitoes have their little temperature-dependent processes of their life cycle and their physiology. All of these are temperature-dependent, and so you can create curves, again, temperature-optimal curves for these two mosquitoes, the ones that spread these infections. Aedes aegypti on the right, which loves it hot at 29 degrees, and then Aedes albopictus, which is around 26 degrees. So we went back to our sites in Kenya and asked the question, well, do we see increasing dengue and chikungunya at our study sites with increasing temperature? And it turns out, yes, we have lots of dengue and lots of chikungunya in Kenya where I work, and it continues to increase as the temperature is getting hotter. And so when we ask the question, well, where in the world is transmission going to be suitable for Aedes aegypti, a mosquito that really actually likes it hot? As the world warms, there's just going to be more and more of the world where this mosquito is going to be able to transmit its infections like dengue, chikungunya, Zika, and even yellow fever, which I'm not talking about today. And it's going to be able to do it year round, which is actually really important for dengue, where when you have multiple outbreaks of different serotypes within the same year, you could be putting people at risk for more severe disease. And so here are the curves for malaria because of the Anopheles gambiae at 25 and dengue, the Aedes aegypti mosquito, at 29 degrees. And when we ask the question, well, what's going to happen across Africa with these infections? Again, malaria is going to shift across the continent, and dengue risk is likely to just expand and expand over time. And this is really important because, at least where I'm working in Kenya right now, we don't regularly diagnose dengue in the health clinics. It's not regularly diagnosable like malaria is, and most of the mosquito control is focused around distribution of insecticide-treated nets. But that doesn't work for this mosquito because this is a day-biting mosquito. So that's not going to protect people from these infections. So we need to move towards more integrated vector control management so that we can deal with Anopheles gambiae, malaria, and Aedes aegypti and dengue. So again, when we ask that question, well, how's climate change going to shift disease burden? It really depends on where you live in the world, what infections are there, what vectors are there spreading those infections, and the temperature by which, where you naturally fall on the temperature curve when we think about temperature and its impacts in these vector-borne diseases. We did look also at extreme weather events because extreme weather events can also have an impact. It's not just all about temperature. And we tried to classify events as floods, droughts, heat waves, or cold waves where we were working in Kenya and tried to look at the impact of those on vector abundance and dengue risk. And we found that floods resulted in higher vector abundance and generally higher risk of dengue. And that makes sense because of the life cycle requiring water. But it's actually quite complex and nuanced, right? Because it turns out that chikungunya, a mosquito virus, as we just spoke about, that it's actually spread by the exact same mosquito species, Aedes aegypti, can actually be linked to drought. And so how can that be? Floods, but then also drought. Well, it turns out that these mosquitoes love to breed in our plastic containers. And you can see that during drought situations, many people without safe, reliable access to clean water will have containers of water that they hold for household activities that are often open to the atmosphere. And so these can become breeding grounds for mosquitoes. And this just underscores the need for safe water storage during drought relief operations, and also just the intersectionality of all of this. The structural and social determinants of health, which often underlie a lot of exposure to these mosquito-borne viruses. These really are neglected people and neglected diseases. I have, for many years, talked about how arboviruses actually are neglected tropical diseases and tend to affect the impoverished more severely and continue to promote cycles of poverty because they do cause long-lasting sequelae, right? And so climate change is really going to exacerbate a lot of these health and social inequities in our world and disproportionately impact vulnerable communities, right? Those who are outside, those who don't have adequate housing, and so forth. And so we must think about that as we're thinking about these infections and how to prevent them. So you can actually use Aedes aegypti, the mosquito that spreads these arboviral infections, almost as a dipstick for an indicator of climate change, right? Because this mosquito loves it hot and is going to continue to find itself in new areas, in new places, spreading these diseases. And I can tell you where I live in California in the United States, Aedes aegypti has now come to us, and we actually have had local dengue transmission in California for the very first time last year. And so more and more of the world is going to see these infections. And so there are a lot of challenges here. We're talking, many of these infections are moving to new places. And so we're going to have non-immune populations who then get them. And so there's going to be huge numbers of outbreaks. and the outbreaks will be large, which can overwhelm health systems. There are a lot of overlapping risk factors, like I've been talking about, and intersectionality with poverty. There are many widespread competent mosquito vectors. They're likely to adapt to warming temperatures. We don't have a lot of rapid local testing, at least where I work in Kenya, for a lot of these viral infections. And there's limited physician knowledge and clinical suspicion and fairly poor diagnostics overall, and not a lot of treatments or vaccines. But I will say that appropriate diagnosis and accurate diagnosis can lead to supportive care, which can be life-saving in many of these infections. How do we prevent these infections? We prevent the bite of the mosquito, of course. And so that's through repellents, through barriers, through household design to make sure our household, airtight from these mosquitoes entering. And then there's, of course, vector control, which can be done at the household level. Source reduction is actually really important for Aedes aegypti. That's just dumping out standing water because they don't fly very far. And if your household is not one where they're finding feeding and places to lay their eggs, they may move on. And then there's community level vector control, right? Again, at least with Aedes aegypti, bed nets don't work because they don't bite at night. And so you have to go about dealing with them in other ways. And then human behavior really matters, right? Again, I mentioned we can bring these infections with us wherever we travel. And the way that we change the land, including with trash, which I'll talk about in a second, really can create a lot of mosquito habitat and then bring risk to our communities for these infections. So for about the last 10 years now, I've really worked on the intersection of the plastic pollution crisis with vector-borne diseases. And this is connected to climate change because when droughts come, again, people use plastic containers and fill them up and they become mosquito breeding factories. And when floods come, all of the plastic trash laying around actually fills up with water and then breeds these mosquitoes. These mosquitoes only need about a tablespoon of water to lay their eggs. It's not very much. And so a plastic container is perfect for them to find that little niche, that little bit of water to lay their eggs. And so in order to deal with this, we do a lot of research, but we really wanted to get it at this plastic pollution and environmental health crisis. Really from the community level. About 3 years ago, we launched a nonprofit called the Health and Environmental Research Institute Kenya. And this is an initiative focused on Kenya to really inspire grassroots education, new research, policy change, and activism in these environmental health issues like the waste crisis, and really focus on healthy environment, healthy human, right? And so we've now launched an education hub to build awareness and community action. We're doing a lot of convening and strengthening relationships to bring people together, destigmatizing trash collections and actually creating circular economies of waste so that we can clean up the environment and actually create jobs and economic opportunities for folks while we do it, and then decrease those mosquito-borne and trash-related health risks and improve the trajectories of health for communities on our planet. So please follow us. We have a gala coming up on December 15th. We're going to be talking about all of our work in this space, and you're all very welcome to join us. So I've talked about unmeasured factors in vector-borne disease today. I've just talked about solid waste and how trash and plastic in particular can become mosquito breeding grounds. I talked about the built environment. These infections are intricately linked to the space and the environmental context around them. So dams or household construction, all of this makes a difference when we talk about these vector-borne diseases. I talked about governance and how education control programs and other support are needed for prevention. And then the structural factors that are underlying risk for all of these things, right? The overlap of the health inequities and the poverty that underlie it all. So what can we as health professionals do? Well, I believe we're uniquely poised to promote resilience to climate-related stressors, right? We can recognize that not all individuals and communities are impacted equally by climate change, and that these disease vectors and diseases are expanding their range. So we have to stay curious and open to new diseases. We need to look at each patient individually and figure out, okay, what's their risk? Take the time to really do participatory guidance during visits. We need to put pressure on our ministries of health to increase surveillance and detection of these infections in our health systems, right? Not just malaria, and stay in contact with other health professionals. Because again, we live on a very small planet, and the animal populations are also getting impacted by these diseases. When West Nile came to the US in 1999, it was the veterinarians noticing that all of the wild birds were dying at the zoos and that birds were dropping dead out of the trees. And they figured out that West Nile was circulating before we realized what was happening in human populations. So we really need to all be connected and sharing information, right, amongst public health, veterinary health, the climate science community is really to build science or to build climate resilience while planning vector-borne disease prevention and response activities at the community level. And then finally, apply a health equity lens to the framing, understanding the co-benefits of climate resilience action, right? Again, we need to promote policies that simultaneously improve health and reduce the health inequities. So to conclude, climate is really important for determining where and when conditions are suitable for vector-borne disease transmission, right? And as I showed you with Rift, we can have a map that sort of shows us when the conditions are right, but that doesn't necessarily mean every single time the condition is right, there will be an outbreak, right? It's more nuanced than that. We believe that climate change is really going to exert a nuanced effect on vector-borne disease transmission, and that depends on the location where you are. It depends on what the temperature is where you are and what you're doing with your land use changes where you are. Climate is likely to promote a shift from malaria to arboviruses in many parts of sub-Saharan Africa, and I don't think we're well prepared for that. I also think there's going to be a shift in schisto burden across Africa. Surveillance and education are critical to monitoring these changing patterns and really mitigating the public health risk associated with them. It could be that disease incidents and vectors and reservoirs in humans are actually serving as potential indicators of climate change, but we don't want that, right? We want to be proactive and have early warning systems and connected, coordinated efforts so that we can abort outbreaks right when they begin or even prevent them before they begin. And again, the degree to which climate suitability translates into disease changes also depends on many other factors. Pathogen exposure history, because herd immunity really does make a difference. Housing type, again, is your house, impossible for a mosquito to get in? That's what we want. Vector control and public health efforts that target all these different vectors and pay attention to the different vector ecology for all the different mosquito species that spread infections. Human mobility and behavior. Again, humans move around and bring these infections, and that can have an impact. The way we change our land, the way we create mosquito habitat when we build dams or when we do the projects that we do. Pollution, because plastic pollution in particular loves to be a home for Aedes aegypti mosquitoes. And then finally, global inequities, which underlie it all. So I just want to thank you. Hopefully I didn't speak too long. Thank you very much for the opportunity to talk with you. And I will pop off. Thank you.
Thank you so much. And we are looking forward to more questions. You can put your questions in the Q&A whilst we take the second presentation, which will be a case study. It's going to be led by Dr. Adugna Woyessa. Dr. Adugna is an epidemiologist and a senior researcher working for the Ethiopian Public Health Institute. His research focused on malaria epidemiology and its relationship with climate, in which he filled the knowledge gaps as an author and co-author of above 40 publications. Dr. Woyessa was instrumental in improving the access, use, and availability of climate information through his research work that assessed the association of ENSO and epidemic malaria in Ethiopia using enhanced national climate services, which is available as the NMA's map room. He was also a member of the National Research Ethics Review Committee from 2014 to 2022 and contributed to revision of national guideline and review. Dr. Woyessa has been a focal person in the Ethiopian health sector since 2017 and led seasonal assessment of health impacts of seasonal weather and climate forecasts organized by the Greater Horn of Africa Climate Outlook Forum. He was a lead author to the IPCC SAID assessment from 2019 to 2022 and currently member of CHANCE, that's the Climate Health Africa Network for Collaboration and Engagement, with the aim to facilitate interactions and create greater coherence between climate and health. Dr. Woyessa studied biology for his undergrad and parasitology for postgraduate, and he did his PhD in medical public health. Shall we invite Dr. Adugna to give us the presentation? Thank you very much.
Thank you, my sister, for the rich introduction. I'm very much delighted I'm part of this system. And Greetings to all. Now I had a good presentation. My sister brought a lot of things to the audience, and now I'm going to take 20 minutes to stay with you to present how my slide is moving. Okay. I'm trying to move my slide. I think it is not moving from my side.
Try the left and right cursor. I had a similar challenge.
Yeah, let me stop sharing and share it again. Oh, I have similar problem.
Should I try sharing for you?
Please do that.
Oh, okay. Please stop sharing.
Yeah, I've stopped sharing.
Okay. Okay.
Thank you, my sister. Thank you very much.
You're welcome.
Yeah, I'm sorry for the glitch we encountered. Today I'm going to share with you how malaria epidemiology in Ethiopia is related to El Nino Southern Oscillation. So as an introduction, malaria is a major problem in Ethiopia. So this disease is seasonal and unstable, which is occurring in the form of epidemics. When we see the epidemiology of malaria in Ethiopia, it is highly related with climate. Ethiopia is one of the East African countries with diverse topography, which is located between two climates. That is, it is in the eastern side, it is boundary with Asian and with the southern, with the western. So we are experiencing a diverse climate. Ethiopia has highland areas at central areas and lowland areas at its western and eastern parts. So as you can see from the right side of this slide, the Ethiopia map has some greenish to yellow areas, which are highland areas, and a lot of rivers that are originating from the central part of Ethiopia. So the rainfall and the humidity is one of the essential components of the environment that limits the distribution of mosquito, especially their survival and development, as we have seen. So as we can see, there are a lot of rainfall variability. If you take the upper graph, we can see a bimodal sort of rainfall in certain parts of the country. And in certain parts of the country, we find with high rainfall during the May rainy season during July, August, with more than 7 months rainfall. And there are areas with, especially southeastern Ethiopia, there is a bimodal in which the rainfall amount or magnitude is very low. Taking how this distribution of rainfall is affecting malaria in Ethiopia, taking one of the severe epidemics that occurred during the end of 1950s, more than 100,000 square miles of 4 central provinces of highlands of Ethiopia were affected, which covered highest portion of the highlands of the country. And this epidemic occurred between June and December. And the altitude limit of the epidemic was between 1600 and 2,150 meters above sea level. So these are areas with population with low immunity because of seasonality of malaria. That means infection is very low in those areas or absent. So by that time, about 3 million people were affected, and 150,000 people were estimated to die because of malaria. So this was preceded by food shortage during 1957. That means a crop failure that resulted in, which is associated with high mortality. So from this, the authors documented that unusually abnormal weather was documented during that time, especially rainfall that exceeded the normal, and the temperature was also high. These were some of the things documented even during early 1960s. Next slide, please. So maybe to say, to put some points about El Nino. El Nino that is affecting certain parts of Africa, especially dry situation in July to September in western and some central parts of Africa, wet during October to January in tropical areas, and dry conditions from November to March. That means El Nino is affecting, El Nino and La Nina are affecting different parts of the continent in different ways. So when we take the climate of Ethiopia, we have three main seasons related to rainfall. The first one is dry. That is within October to January. And the second one is the short rainy season, which is extending from February to March. And the third season is the main rainy season, which is from June to September. So when we take how El Nino Southern Oscillation, or the three phases of INSO affect Ethiopia's climate, if you take El Nino, the impact is drought, mainly in northwestern Ethiopia and northeastern Ethiopia. This is the main rainy season. And similarly, it is resulting in increasing of rainfall in southern part of Ethiopia, especially during the minor rainy season. If you take La Nina, it is resulting in above average rainfall in northwestern Ethiopia during the main rainy season. Next slide, please. Thank you. So one of we have, and some workers related to what we did, especially one of my contribution with my research team was that low prevalence of malaria that is varying with altitude. We did this study in highland and highland fringe areas of Ethiopia, which is the southern part of Ethiopia, which is around 135 kilometers from Addis. And that area is located between 1800 and 2300. So this is where the study is located. And so what we found is that for low altitude areas, which are around 1800, we see how there is a high variability of malaria prevalence. This is a study which is conducted for 3 years. And in this 3 years study, we identified that there is existence of endemic malaria above 2000. This is one of the things which is not well documented in Ethiopia. We used to have malaria program operation in areas below 2000. That means areas above 2000 elevation used to be known as malaria-free, or malaria is occurring sporadically during epidemic years. So from our longitudinal study, in which we have collected more than 20,000 samples, we identified that malaria is occurring in highland areas of Ethiopia below above 200, which was an eye-opening for malaria program to revisit its program to move up and include areas between 2000 and 2300 and beyond that for surveillance and strengthening the malaria diagnosis and the treatment. Another evidence for encroaching of malaria to highland areas was that a study which was conducted by a team at Columbia University, in which they identified increases in elevation for both 18 degrees Celsius and 15 degrees Celsius threshold in highland areas between 1981 and 2014. And those, this 18 degrees Celsius is the threshold, upper threshold for Plasmodium falciparum transmission. And this 15 degrees Celsius is for vivax. So totally it was estimated that 6.5 million more people were at risk of malaria. And of these 2.2 million people were estimated to be due to falciparum malaria. So from this, what we learned is that malaria is moving up against the elevation beyond the malaria program operation areas. That means for vector control activities and the case management. Next slide, please. Maybe one of the things I'm going to present is a case study. So the context of my presentation relies on one of the things in which our gathering during 2014 in Addis, a team came together from Columbia University and the malaria community in Ethiopia. They came together and they asked themselves, how can we inform policymakers, decision makers, how El Nino is going to affect malaria transmission in Ethiopia? Because 2014 was forecasted to be El Nino year, and we're not sure how to tell malaria program how this forecast is going to affect malaria. So this team, the picture you can see, this team is headed by Dr. Thompson and her team from Columbia and other people from Mailman School of Public Health. And we sat together and we had workshop in which we have identified how infectious disease surveillance could be use the climate information available from National Meteorological Agency. And we had a small team that came together during 2008, and in which we have created Climate and Health Working Group, which was established during February 2008 and generated a publication, Public Health and Weather Services, Climate Information for the Health Sector. This was authored by the current Director General of WHO and the team in Ethiopia and the USAID and other partners. So we have a request from Ministry of Health to have a quality controlled climate information for supporting decision in malaria program. Next slide, please. So with this, we had the aim of undertaking exploratory analysis that can inform the use of climate information in Ethiopia Ethiopian Malaria Control and Adaptation Program. As you know, National Health Adaptation Plan is also encompassing many programs, including malaria program. So our aim was to inform the health sector overall and specifically malaria program, how the past climate situation was influencing malaria distribution. The first objective was to see the impact of insophasis on the seasonal and the spatial patterns of rainfall and the temperature. That means minimum and the maximum temperature across Ethiopia using ENACT's Enhanced National Climate Services Graded Climate Data. As I've already mentioned, the Climate and Health Working Group was, that means team of researchers and the program practitioners came together and they worked together to have quality climate data. So the climate expert at Columbia, they initiated ENACTS, which was initiated in Ethiopia, in which they generated graded climate data. That means through combining satellite and observed climate data. So I'll in a few minutes I will give you detail about that. The second objective was to review the occurrence of malaria epidemics at local and widespread across Ethiopia, as recorded in peer-reviewed and gray literature that is coming from different reports of Ministry of Health and the Malaria Program and other sources. So we also consider drought in this regard. Next, thank you very much. So maybe my colleague mentioned, Dr. LaBeaud mentioned the objective of our learning objective for this audience. And my focus will be to explore what actions health professionals can take to identify and protect their patients vulnerable to various climate sensitive diseases in their respective geographic location or regions or region. Particularly, I'm focusing on malaria, taking the case study from Ethiopia. So the climate sensitive diseases, as we can see from this graph, there are a lot of climate sensitive diseases as documented during the end of the 1990s. A climate-based distribution model of malaria transmission, which is the output of MARA project. Next slide. So our approach was the new climate data. That means, as I've already mentioned, ENACT is one of the areas that expanded in improving the climate data. This is one of the areas which is initiated in Ethiopia, and currently, at least you can see from the map, there are areas that have already benefited from ENACTS, that is availing climate data in a graded form through combining observed and satellite data. Maybe you can access this, what is ENACT, how it was initiated. You can see the details using some of the things I've tried to include in my presentation. So the relationship of historical malaria epidemics, local, when we say that is in a limited area and widespread, that is covering wider areas. How this is concurrent with insophasis, that is El Nino, neutral, and La Nina, and how climate conditions, including drought, was explored in various ways. So as you can see, I don't want to go to the details of how El Nino is occurring, how La Nina is appearing, and this is one of the climate systems that is affecting Eastern Africa, particularly the Horn of Africa, in resulting into flooding and the drought in different parts of the country during different seasons that are occurring in Ethiopia. Next slide. Next, thank you very much. Yeah, so coming to the sources of data that we have used, our sources for historical malaria epidemics was obtained from literature. We went back to cover documents or articles that are published during the 1950s to until 2016. Maybe one of the things we took a long time to come up with data. We have started this some years back, as I've already mentioned, and we included also the 2015 El Nino year. And I've already mentioned how these enhanced national climate services and MAPROOM, that means when we say MAPROOM, that is where you can access map of different impacts of climate in various forms that can be used by the health sector, the agriculture, water, so on and so forth. So at the right side, you can see when you go to this MAPROOM, you can see how the health data, you can see this is the surveillance suite for malaria that we have developed and generated. And I'm indwelling what we have designed together and what we have generated. Next slide, please. Yeah, this is what we have managed to generate. As you can see, the partnership between International Research Institute for Climate and Society at Columbia University and Ethiopian Meteorological Agency, which is renamed as Ethiopian Meteorological Institute this time. We have this INACT data that is high resolution merged satellite or session data. And you can see these figures. This is what we have generated. As you can see, El Nino's impact on rainfall, especially on figure 2, temperature. You can see extreme temperature. That is a high probability of higher temperature in western and northern part of Ethiopia. And you can see the OND, October, November, December, El Nino in El Nino years have higher probability of high rainfall in southeastern Ethiopia, as you can see from figure 4. And figure 5, you can see the La Nina is associated with the reverse effect. Next slide. Thank you, Mariam. So immediately moving to our finding, altitude is one of the important factors in epidemic occurrence. Epidemic events were in recorded highland regions. We identified 36 epidemics of various magnitude, and 17 of them occurred in highland areas, and 15 of them in highland and lowland regions. So we can see from the right side, you can see the summary that during neutral year, widespread epidemic was 1 and the local was 2. During El Nino, we had widespread epidemics in 10 of those epidemics, and 4 of the epidemics were in local area. During La Nina, we had 4 epidemics at wider scale, and we can see the combined one 4 and at local 3. So we understand that there is a maybe bias related to recording of epidemics. Maybe not all epidemics might recorded, and our publication or recording bias may affect. But in our exploratory assessment, what we have seen is that most of the epidemics occurred 14 malaria epidemics occurred in 10 widespread areas, as I've already mentioned, and 29 of 65 years have recorded widespread or local malaria epidemic or outbreaks. 12 widespread epidemic events were associated with drought years. All strong or very strong El Nino events were associated with drought in Ethiopia, and the drought occurred in association with 5 of 8 moderate El Nino events. Next slide, please. So, moving to the last part of my presentation. As a conclusion, the Ethiopian Meteorological Institute's MAPROOM and INACS data, it provided an important resource for climate analysis by the health community. This is available this is one of the aims of INACS was to make climate information accessible and usable by health professionals and other sectors. So INACS is one of the potential areas where health professionals could use to understand their local situation, in which season, in which area of their operation, which climate parameters are occurring during INSO, and how they can align their planning their intervention. So the other thing is that this is available in a website that can be accessed, and this time we are planning to do training for districts which are epidemic prone, and Ministry of Health is trying to align health professionals can use climate information for malaria program operation. So higher temperatures and rainfall are important factors in driving epidemics at local and regional level. Next slide, please. Yeah, this is the last slide. As a recommendation of the way forward, maybe country participants from countries having INACS in their system, they can use analysis at district level or at smaller administrative unit. And the other thing is that enhanced partnership of health and the climate community, and advance their to create a community of practice together and on how climate is affecting their day-to-day activities, planning vector control, and the deploying of health communities to the local community. Last slide. Thank you very much. Our recent publication is summarizing the thing I've tried to present. Dr. Thompson, Asher, Dr. Tufa is a brainchild of INACS, Aisha, and my colleague from Colombia. So the Ethiopian Meteorological Institute, IRI, Ethiopian Public Health Institute, my institute, WISER, they have supported our work that we have started during 2008, and that we are also advancing this time through application of this at local health system. Thank you very much, audience. I might have taken more minutes. I hope Mariana will have tolerated me. Thank you very much. Have a great day.
Thank you so much, Dr. Adugna, and thank you all for listening and your patience. We are going to move on to the Q&A. We've been told we have to work together as a team, both the environmental scientists, health workers, and the veterinary officers. We have limited time, so we won't be able to take all your questions. We will take some questions for our presenters. Okay. So the first question will be to Dr. LaBeaud. Okay. Okay. So the question is, extreme weather events such as tropical cyclones, floods, waves, and droughts extreme weather conditions such as tropical cyclones, floods, heat waves, and droughts, etc. Evidence has shown that of these owls, there's the mosquito, the owls vectors. However, the country is limited in diagnosing arboviruses such as dengue, which limits knowledge of the real epidemiology of the disease, the impact and the extreme weather events have in relation to transmission and monitoring of the abundance of transmission mosquitoes. So the question is, what do we do to this complicated context as a country? Dr. Woyessa, can you please take this for us?
Yes.
Hello?
I can hear you, Mariana.
Okay, so the question is, the country, that is Mozambique, is limited in diagnosis arboviruses such as the dengue, which limits knowledge of the real epidemiology of the disease, the impact that extreme weather events have in relation to transmission and monitoring. So the question, what do they do in this complicated context as a country?
Well taken. Hello?
Should I give you the second question while you wait? You get the first one.
Yeah.
So the second, okay.
Sorry, Maria. Related to chikungunya, just I can give opinion, but
okay.
Dr. LaBeaud presented it very well, and she knows the area very well. But I can give opinion related to the Ethiopian case.
Okay.
Is that okay?
That's fine.
Yeah, thank you.
Dr. LaBeaud, will you give us your version? Give us an input on this question.
Just about the integrated control. Yeah, I mean, it is very difficult, right? There's so many different factors that are involved and so many different people to coordinate. As I mentioned, if I understand your question correctly, can you restate what the question is?
Okay, so the country is limited in diagnosis arbovirus such as the dengue, which limits their knowledge. So they want you to tell them how to deal with this complicated context in their country.
It's really difficult. So that's why it said in my presentation, I think it's important for us to actually advocate as healthcare providers, advocate in the systems that we work in when things need to change. I actually believe that one of the main things that needs to be done, at least where I'm working in Kenya, and we work with the Ministry of Health, is to really see if we can bring in diagnostics to rule in infections other than malaria. Because that way we can have a more accurate understanding of what's happening. In Kenya, where we've done our research, when we've looked at, everyone gets a malaria test who has fever. And so when we looked at the children who have dengue in our study site, acute dengue, so that means they actually have dengue virus in their blood, half of them actually also were malaria parasitemia positive. So that means there's a large proportion of patients that are actually most likely being misdiagnosed as malaria because the other infection isn't being ruled in. So I think it comes down to advocacy, finding partners. You know, you're not going to do this alone, but you know, finding partners, bringing data to your colleagues. People are reasonable, right? And the problem becomes that it's limited resources. We have to do a lot with not a lot of resources, and so. But I truly believe that as the climate is warming and these infections are becoming more and more common, it is a good use of resources to actually start to understand these infections and how prevalent they are in the different places, so that we can provide better care to our patients and then have a better understanding of the control that we need to do in the community in order to prevent infections.
Thank you so much, Dr. Labu. So the next question is, even though we've put in several interventions and resources to prevent and manage malaria, there are still outbreaks. So in your perspective, what unique and different approach can be used to address the increasing malaria outbreaks in Africa? Dr. Labu?
Yeah, well, so one of the things is what I'm really worried about is the new vector for malaria that's spreading across Africa, Anopheles stevensii, because we already have problems with Anopheles. With Anopheles gambiae. You know, it's complicated. As we've been talking about, right? All of the different factors that lead to transmission of these infections. They can be because of the system, they can be because of the environment, they can be because of human behavior, right? So there's so many different things to think about. But one thing I just do want to bring up, and I didn't bring it up in my talk, but Anopheles stevensii, which is the new sort of urban vector of malaria, I'm very concerned because that mosquito acts a lot like Aedes aegypti. It likes to breed in man-made containers instead of natural water bodies and such. And so I think that there is a lot of risk in the urban setting for that vector to take hold and cause a lot of urban malaria. And so again, I think when looking to the future, I think we can think about integrated vector control and thinking about how all of these different vectors like to behave and what are the different control measures we need to use and integrate in order to control the old vector, Gambi, and also the new vector, which is acting a lot like Aedes aegypti. Dr. Woyessa, what do you think?
Thank you very much. I think this is one of the issues currently we are facing. Resurgence of malaria is happening currently in Ethiopia, especially since 2022, we are experiencing resurgence of malaria. So as we are well aware, Africa is contributing more than 90% of the malaria cases and the deaths. And WHO has published this annual report that the malaria program is facing, the challenges that we are facing, the appearance of the species which is limited to Asia is crossing to Africa, and that its role is yet to be elucidated. Still, we have to fear this, we call it exotic species in our setting. Yeah, because it is resistant to most of the insecticides in use. It predominantly breeds in urban settings, and they use breeding places that is shared with Aedes aegypti. And the eastern part of Ethiopia is experiencing outbreaks of Chikungunya, Dengue. The first dengue case was documented in eastern part of Ethiopia. First it was in Kenya, if I'm not mistaken. Then now it is almost all closer to the central part of Ethiopia where this species is documented. And currently there are investigations going on whether this Anopheles stevensii is dominating or it is occupying area, western part of the country where most of the outbreaks of resurgence is happening. But one thing we have to understand very well is that Ethiopia is one of the highland areas that experienced malaria in areas where endemic malaria not used to be. That means there is a inclination that highland malaria is predominant this time. But we have to take also the role of those areas. Whether imported malaria is creating an opportunity for the establishment of local transmission of malaria. So there is a publication that came from people from the Washington University. They published maybe a year or before 2 years in the last 1 century or the mosquito ecology has moved upwards to the high altitude area. I forgot the exact number, but it moved upward. That means they took the average where mosquitoes are occurring and able to transmit, not their presence able to transmit malaria. So the issue is complex, and if we understand, if we unfold how climate is interacting with the vector-borne disease, we can understand more how malaria is also taking advantage of this warming temperature. Over to you. Thank you very much.
Thank you so much. The next question to Dr. LaBeaud, and how can One Health approach be applied for connecting human malaria control and zoonotic diseases in controlling mosquito population? Dr. Adugna can also give inputs.
Yeah, so taking a One Health approach is quite important with many of the diseases I've talked about. When I think about vector-borne diseases, I think about the arboviruses in particular, because many of these infections have life cycles that include animal species. I mentioned the Rift Valley fever life cycle that includes livestock and domestic animals as important amplifying hosts. In Rift outbreaks, the animals disease and animal outbreaks are hugely important for prevention of human disease, because often we before human disease gets noticed, you notice that your herds are aborting, or that your animals are getting sick, or young animals are dying, or they're showing signs, bloody noises and things, where you worry that there may be a Rift Valley fever infection, and they can be really important sentinels for transmission in the community. I mentioned the West Nile example here in the United States when the birds were dying, and so that's how West Nile was really detected here. And there are many, many examples. I mean, my mind also is going to recently when there have been the large outbreaks of yellow fever in Brazil in the late 2000s, 2016, 17, 18, and what was happening is the monkeys were dying and falling out of the trees, right? And so we don't want to just use our animals as, animal deaths as sentinels of infection. But that is an important thing to be aware of and to really take note of. And so I think coordinated conversations and One Health strategies to preventing these infections that have important animal reservoirs are really incredibly important. Taking that approach and then doing surveillance in animals to be proactive. Looking for transmission among animals before the herds start dying and before the abortion storms start, so that we can know when effective vaccination is useful, at least in the case of Rift Valley fever where we have a vaccine. So I think it's about bringing people together, developing coordinated sort of sentinel proactive surveillance approaches. And then when outbreaks happen, really making sure that resources are distributed to protect animal populations and human populations as well. Dr. Woyessa?
Thank you very much. This is one of the challenging things, because this One Health approach is one of the areas that is flourishing area, and that requires also coming together and collaborating, as my sister already mentioned. Maybe one of the things I would like to take as an advantage is that there is African Research and Impact Network. That is trying to be a champion in Africa and would like to demonstrate how transdisciplinary research could address our gaps. So this is one of the areas that is where we need experts to come together. Taking malaria as an example, the fifth species of malaria is zoonotic. That is, still, while we're designing elimination strategy for malaria, we have to also develop zoonotic malaria. That means the species that is finally coming to affect human should also be monitored. So there is no, we have to remove silos because our solutions are finally addressing the community, the society. The society has a problem in terms of animal, ecological, and public health. So if you go to a village, that means a villager expects you to solve their problem in terms of animal health, human health, and their environment or ecology where they are growing their, that means where they grow their plants, and everything is connected. But unfortunately, the science is getting diversified, silos, specialization, all those things are disconnecting us. But this is the time when we have to bring our expertise and the skills together. And we have to have postgraduate program, especially who are going to address the problem that our rural and urban settings face altogether. Thank you very much. Over to you.
Thank you so much. Thank you, Dr. Adugna and Dr. LaBeaud, for the excellent and comprehensive presentations. We are most grateful. Please be reminded of the survey. The link has been put in the chat. Kindly respond to the survey for us. Thank you for your time. And next week, Tuesday, we are going to have the next section on climate extremes, agriculture, food security. Thank you all and have a blessed day.
Thank you, Marian, for moderating this session and hosting us. Thank you very much. I'm very much delighted.
Thank you too.